Alright, so last time we left off after finishing urinary incontinence. So we discussed the three different types of incontinence. At the bottom, I had more details about how to treat each one. The pharmacology aspect is often tested. At the top, I added some information about the neuroanatomy of how voiding just works in general and how urinary incontinence is maintained. Then we did some practice questions and we looked at a bunch of images detailing, how the anatomy looks like and what the neuroanatomy behind it is. And so all that is really important stuff. You want to make sure you're able to talk about all three types of incontinence without having any issues and without really, getting confused about it. And then one more thing that we saw yesterday, which it was mainly just like a introduction because it's going to be mentioned more in reproductive, but the pudendal nerve, right? So the pudendal nerve we saw here is going to be important for the external urethral sphincter, okay? So that can be damaged during vaginal childbirth, and that's something you have to remember because we're going to see that again when we get to reproductive. And at the bottom here, we had a question we didn't do. So let's start with that, and then we'll go into the rest of renal path. So a 23-year-old premigravida woman vaginally delivers a 3,600-gram girl after a protracted labor. The patient sustains second-degree laceration and repair is planned. Prior to administering local anesthesia, the operator intravaginally palpates bony protrusions located posterolateral to the vaginal sidewalls that are distinct from the rest of the pelvic sidewall. A firm band can also be palpated running medially and posteriorly from the bony prominence to the sacrum. So this image on the left is kind of talking exactly about what's being described here. But this image obviously wasn't given until you got to the explanation, right? But the anatomy that they're describing of what the patient is working with, what the doctor is working with on the patient, is what's being shown here. So the firm band would be this right here, the sacrospinous ligament. Anesthetic agent is injected around the bony prominence. Which of the following nerves is blocked by the injection? So this bony prominence is your ischial spine. And that's what you were supposed to figure out from the description they're telling you. And the nerve that'll get turned off is going to be your pudendal nerve, right? So the pudendal nerve. Important landmarks for a pudendal nerve block include the ischial spine and sacrospinous ligament. The ischial spines are bony protrusions located posterolateral to the vaginal sidewall. Other important landmarks include the internal pudendal artery and inferior gluteal artery, which run medial to the pudendal nerve. Not the most important thing, but those arteries will be there, so you want to be careful if you're going to be injecting in that area. So that's something that you can get tested on. Pudendal nerve is obviously very high yield, and we're going to see a lot more pudendal nerve action when we get to reproductive. Now the next page goes into the last few renal issues that you're going to get questions on. So the first thing we see here is acute cystitis, and I added a lot of microbiology information right here on the same page just for revision purposes. So acute cystitis is inflammation of the urinary bladder. It presents as suprapubic pain, dysuria, urinary frequency, and urgency. Systemic signs like high fever and chills are usually absent, which is very important to remember. Risk factors include female sex, sexual intercourse, indwelling catheter, diabetes, and impaired bladder emptying, which is relevant to what we just saw, the urinary incontinence stuff. Causes can be E. coli, that's the number one cause of UTIs in general. Staph saprophyticus, the number two cause of UTIs, and very common in sexually active young women. But see, even here, E. coli is still more common, so that's why staph is second. Klebsiella and Proteus mirabilis, where the urine is going to have an ammonia scent, and we saw Proteus mirabilis earlier when we did the renal stones, and that's the one that had the staghorn calculi. So lab findings are going to have positive leukocyte esterase, positive nitrites, right, and sterile pyuria. Sterile pyuria, which basically is pyuria with negative urine cultures. Sterile pyuria is going to be something that's going to be a big sign of Neisseria or chlamydia because those two guys, remember, are intracellular. Right, but leukocyte esterase and nitrites are the two things we test for every time a patient comes in with signs and symptoms of what might be a UTI. Okay, if it's positive nitrites, then you think it's gram-negative, and if it is gram-negative, you might want to think Neisseria. If it's a positive leukocyte esterase test, then you go ahead and look at the other options. So on the left, I gave the general characteristics, the whole portfolio of things you're supposed to know critically about those bugs that are on this page. Right, so very important to keep those guys in mind. And of course, positive nitrites almost always happens because the gram-negative organism encompasses both the number one guy, E. coli, and then of course you also have your Neisseria stuff. The rest of this page just talks about pyelonephritis. So this is another case scenario very similar to acute cystitis. So pyelonephritis, you can either have it acute or it can be a chronic thing that keeps happening. Acute pyelonephritis has neutrophils infiltrating the renal interstitium. This affects the cortex with relative sparing of the glomeruli vessels. Presents with fever and flank pain. And this fever, the systemic symptom, is a thing that's a little different from acute cystitis. Flank pain because of the costovertebral angle tenderness, and nausea, vomiting, and chills. Causes include ascending UTI, where again E. coli is the most common. Hematogenous spread to the kidney. Presents with white blood cells in the urine plus or minus white blood cell casts. CT would show striated parenchymal enhancement, and that's something that you don't really necessarily see much of, but they can give you this, right? So something like this in a CT. Now keep in mind that they've zoomed in on the kidney here, right? But usually the CT would have the whole abdominal thing and it would all be there. But yes, the kidney would have portions that are really, really bright. So that's what you're thinking of with, you know, this description of striated parenchymal enhancement. Risk factors include indwelling urinary catheter, urinary tract obstructions, vesicoureteral reflux, and diabetes in pregnancy. The most common things are usually just the indwelling urinary catheter. That's why in American hospitals, management of catheterization is very critical. How often you're supposed to change it, what are scenarios where you need to change it more often, stuff like that. And then urinary tract obstruction is something you'll see in younger patients. So, you know, very important to watch out for any of these case scenarios where a patient presents with acute pyelonephritis. Complications include chronic pyelonephritis, obviously, renal papillary necrosis, which we're going to see on the next page eventually, perinephric abscesses, right? So perinephric abscess, this means an abscess next to the nephrons, right? So very important to remember that as an answer choice. And urosepsis. But this isn't the worst thing on earth or anything like that. You just give antibiotics and you treat it, right? That's the main thing here. One of the case scenarios that you want to remember for diabetes is patients that are treating with medications that can also cause more UTIs. That's very important to remember, the SGLT2 inhibitors. If you're going to be urinating all your sugar out, that increases the likelihood of having a bacterial colonization in the vagina. On the left arrow here, white blood cells will only form casts if there is an infection in the kidney. Otherwise, an infection in the collecting system would lead to white blood cells in the urine, but they would not be molded into casts. As the bacteria ascends, polymorphonuclear leukocytes will be in the tubules thanks to the enhanced permeability after pro-inflammatory chemokines like interleukin-8 do their jobs. Right? So you can see white blood cell casts in this case scenario. Now, if this keeps happening, then you get chronic pyelonephritis, the result of recurrent or inadequately treated episodes of acute pyelonephritis. Typically requires predisposition to infections such as a vesicoureteral reflux or chronically obstructing kidney stones. Course, asymmetric corticomedullary scarring, blunted calyx, tubules can contain eosinophilic casts resembling thyroid tissue. Right, so thyroidization of the kidney, and this is something that's very important to remember. Almost every student I get, like I have a list of things I ask students when I first start working with them, just to see how accurately they remember some of the less commonly spoken of topics, and this is one of them, right? So I'll talk to them like, do you remember what causes thyroidization of the kidney? And I think I've only had one student of maybe 7 so far that actually was able to remember that, right? So no one tends to remember what is thyroidization of the kidney. Now, this isn't actually thyroidization of the kidney. You're not making thyroid hormone or anything like that. It just looks like the thyroid gland, right? So this is what they're showing you here. You can see this big area right here, right? And then these portions right here, the tubules have eosinophilic casts in them, right? And those eosinophilic casts are making this look like you're looking at thyroid tissue, okay? So that's all this is about. What they like doing is, you know, in step 1, they can give you a question that's related to the kidney, and they might talk about some kind of cancer, and they'll be like, you know, where did this cancer come from? This is what the tissue looked like, you know, and then they give you this image of the tissue, and enough information will be given to you in the question for you to figure out that this isn't actually thyroid tissue, it's the kidney. It's due to chronic pyelonephritis, right? So some kind of weird question like that can be presented to you, so be ready. Of course, thyroid tissue looks much more different than this. It's just very similar looking, right? So when we did endocrine, we did look at a lot of thyroid tissue, and let's actually take a quick look at that right now. So let's see. Thyroid. So where's thyroid? Yeah, so you can see like this image right here, right? So you have your colloid, you have your follicles, right? All of that stuff. This is your thyroid gland right here. What we're looking at now doesn't have that, glandular aspect. This is just something that looks like it's a colloid, but it's not, right? Neither is this colloid, right? So what you are seeing though is a bunch of circles, right? A bunch of circles. Those are your tubules. And remember, the tubules are coming out of the page and going into the page. So when you cut it, it's like a bunch of straws, right? So that's what we're basically seeing here. A bunch of straws that are standing. These are all your tubules. This is the kidney. The other thing they mentioned under chronic pyelonephritis is xanthogranulomatous pyelonephritis. This is a rare condition. You'll note grossly orange nodules that can mimic tumor nodules, characterized by widespread kidney damage due to granulomatous tissue containing foamy macrophages. And this is something that's also associated with the Proteus infection. Right, so Proteus mirabilis, we already know the urease positive guy is related to staghorn calculi, kidney stones, right? And kidney stones are something that can cause acute pyelonephritis. Recurrent kidney stones would lead to chronic pyelonephritis, and then you can get xanthogranulomatous pyelonephritis. So you have to remember the question is about Proteus, and they're talking about granulomas, and it is pyelonephritis related. This is the answer choice. All right. So now we have two questions here, one from Amboss, one from UWorld, and this USMLE RX thing. So 3 questions. The Amboss one says, a previously healthy 24-year-old woman comes to the physician because of a one-day history of nausea and weakness. She is sexually active with 2 male partners and uses an oral contraceptive. She uses condoms inconsistently. Her last menstrual period was 4 days ago. Her temperature is high, 101F. Physical exam shows right costovertebral angle tenderness. Pelvic exam is normal. What is the most likely cause of her condition? Let me fix that typo up real quick. Alright, so what is the most likely cause of her condition? So, she's very young. She is sexually active. Doesn't necessarily use condoms. So, oral contraceptives, the difference between using oral contraceptives and condoms, obviously, is the fact that oral contraceptives just prevent pregnancy. Condoms prevent the spread of STIs, right, for the most part. So, since she is sexually active and she just had her period, she's not pregnant, but she looks like she might have gotten a UTI, right? That's why she has her right costovertebral angle tenderness, but the pelvic exam in general is perfectly fine. So she most likely has ascending bacteria from the bladder, right? Ascending bacteria from the bladder, typically due to an underlying cystitis, is the most likely cause of this patient's pyelonephritis, right? So you're seeing a case scenario where she probably started with cystitis, now has pyelonephritis. Other risk factors include pregnancy, urinary tract obstruction, such as a BPH, catheter, or vesicular reflux, and recurrent urinary tract infections. Okay, so in general, this was a very easy question, but the question is here to demonstrate how simply something like this can be presented. And in your answer choices, you can have everything: cystitis, pyelonephritis, pregnancy, whatever it might be. You have to differentiate by looking at the condition the patient has. And one of the main ways to differentiate between cystitis and pyelonephritis is the presence of systemic symptoms, right? She has fever. And we just saw that in acute pyelonephritis, you can have fever, you can have flank pain. In acute cystitis, right, you can have all of these pains and urinary frequency and stuff, but systemic signs are usually absent, right? So you're not going to note high fever and chills in acute cystitis, but you will once it becomes pyelonephritis, if it becomes pyelonephritis. Harriet Lakhani is asking, can catheterization cause UTIs? And yes, they can, because catheterization is basically when you insert a catheter through the urethra and you allow a patient to be able to urinate more easily, you kind of open up the path. You open up the path, and now it's going to stay open, and every time this patient needs to urinate or anything, they'll just free flow urinate. Right, so it's not under their control anymore. As soon as their bladder fills up to a certain extent, they'll start urinating. Now there's an open path, plus there's a foreign object, the catheter itself, which allows bacteria to go up. So you can have a urinary tract infection because of prolonged catheterization that maybe should have been removed, after a certain amount of time, or prolonged catheterization that also got infected by something else that might have been happening around in that inpatient setting. So inpatient settings, it's a very common thing. I haven't looked at the statistics recently, but there are statistics of, for every hospital, there are statistics for how often someone who underwent catheterization ended up having a UTI. And those statistics are taken every month or every year at these hospitals, because the goal is to lower those statistics, right? You want to minimize the number of patients that get catheterizations done and then end up with a UTI. So cleanliness and continuously changing catheters, and definitely removing catheters when no longer needed, are some of the few important steps we take at hospitals to make sure that we don't cause our patients to get a UTI. The URL question here says, a 12-year-old girl, so now we have a half the age patient, 12-year-old girl is brought to the clinic by her parents after she is found to have hypertension by her nurse school. She has no other symptoms and did not receive routine well child care until immigrating to the USA several months ago. She has had several episodes of fever and abdominal pain, which her parents have been able to treat with over-the-counter antibiotics. The patient's blood pressure is elevated on several readings in the office. There's no family history of hypertension. Renal ultrasound reveals dilated calyces with overlying cortical atrophy bilaterally, mostly in the upper and lower poles. What is the most likely cause of her condition? So hypertension, you're thinking some kind of renal issue is happening, right? Most likely she has kidney damage. And then you look at the renal ultrasound, and yes, she does, right? Now, when they're talking about dilated calyces, you're thinking some sort of hydronephrosis kind of issue. And cortical atrophy bilaterally is also a sign of hydronephrosis, mostly in the upper and lower poles. So you look at all your answer choices, and reflux nephropathy was the most accurate answer to pick, okay? Because they're talking also about antibiotics. They're also talking about systemic symptoms. So it looks like, she might have reflux that's causing her to get more infections. She has vesicular-ureteral reflux causing recurrent pyelonephritis consistent with her renal scarring. Normally, ureters travel through the bladder wall at an oblique angle, but here the ureter must be entering more perpendicularly. And this is something we talked about way in the beginning when we started the renal section, under embryology. Renal embryology. Right, I think, yeah. So we looked at normal connections right here, right? In this normal image, you can see the way the ureters are coming down like that, and then you see how it enters. So there's that like angle that you're kind of seeing. It's coming down very nicely, but then it makes this. I'm exaggerating the angle. It makes this like curvature. This curvature before going into the bladder, right here. So this angle thing is very important, right? So now you can see that the entry point has a very unique angle to it when it's entering in here. Now, if anything else happens, then that angle will no longer be the same. As you can see over here, for example, in a duplex kidney, where you have two ureters, the second ureter is not entering at the same angle here. Right, so if a patient doesn't develop the ureter the correct way, maybe it developed a little too far down. See, now it's got this like almost 90-degree angle thing happening here. If the ureter doesn't go into the bladder at the right angle, it can cause reflux, right? That's kind of what we're looking at every time we consider a patient who might have urine reflux occurring in their scenario, right? So that's kind of what this patient most likely had, reflux nephropathy. All right, so this description is exactly that, dilated calyces and cortical atrophy bilaterally. All right, so this young girl, she never really got tested, nor did she get much routine care, as they told you in the question, because she was in another country. They didn't give you what country, but most likely it was a third world country or something. And now that she's in America, she's going to get better care. So, when they tell you something like that this patient just immigrated or whatever, it opens up the scenario to so many more things. The answer choices can be almost anything now, because you're assuming that this patient has gotten no care. Last thing here, USMLE RX, so they give you a 45-year-old man is hospitalized for hip surgery. 2 days post-op, he becomes oliguric. His blood work is notable for a serum BUN of 40 with a serum creatinine of 1.3. Which of the following therapies would be most helpful? Antibiotics, IV fluids, or furosemide? Now, he was hospitalized for hip surgery, okay? And now he's oliguric. That information is enough for you to figure out that this patient just needs IV fluids, right? Giving furosemide is not going to work, and antibiotics just seem unnecessary here. This patient has acute renal failure cleared by the oliguria and the very high BUN creatinine ratio, which means that this is pre-renal azotemia, and this is probably here because we're going into that. Yeah. So this question is here as a prequel to what we're about to talk about soon. We need to increase the volume of fluid going to the kidneys because the problem is decreased renal perfusion. So what this question is teaching you is that when you see a patient with a BUN that's super high, right, and the creatinine is not that bad, obviously it's high because the patient has a problem, but the BUN is much higher. What does it mean when your blood urea nitrogen is that high? What it means is that your body, and your kidney especially, is trying to retain everything because there isn't enough blood coming to the kidney. All right, so there's not enough fluid coming to the kidney, and your kidney is freaking out. It's thinking you're completely hypovolemic, so it's retaining everything. Another thing you would note in this patient is that their fractional excretion of sodium, FeNA, would be very, very low because they're going to retain that too. They're going to retain everything they can because the kidney is working. The kidney is working, so it's able to retain things, but it's pre-renal azotemia. Things are not coming to the kidney. Okay, so that's what we're going to look at now on the next page. Acute kidney injury, one of the top, what was it? I think I said there's 5 topics in renal that are very, very critical. This is the 4th one right now. So acute kidney injury. Formerly known as acute renal failure, acute kidney injury is defined as an abrupt decline in renal function as measured by high creatinine and high BUN or by oliguria and urea. Now there's pre-renal, intrinsic, and post-renal azotemia. The pre-renal azotemia is what we just saw in that USMLE question earlier. That was due to a decrease in renal blood flow, such as in hypotension or hypovolemia. That leads to decreased glomerular filtration rate. With lesser blood coming in, there's lesser filtration. The sodium, water, and urea are retained by kidney in an attempt to conserve volume and fix that hypotension. So that causes you to have a very high blood urea nitrogen because you're retaining it, and you're going to have a very low fractional excretion of sodium. Okay, so you stop throwing anything out. Now, the reason you're able to do all of these fixes is because your kidney is actually working, right? If you ever get a question where BUN is high, fractional excretion of sodium is low, these are things telling you, who did it? The kidney did it. So if the kidney did it, that means your kidney is working. Okay, so that point is when you can realize this is pre-renal azotemia. Something is wrong somewhere else, not the kidney. Right, so that's pre-renal azotemia, a very common scenario. This can also be presented as a experimental question where they'll tell you, like, they clamped the arteries going to the kidney. It can also be seen in scenarios where patients have renal vascular disease, right? So if they have renal artery stenosis, again, that'll also have decreased renal blood flow. Okay, so any case scenario where we have low renal blood flow can have pre-renal azotemia scenarios. High BUN and very low FeNA, as you can see on this table down here. Pre-renal, right? The urine sodium less than 20 because you're not excreting any of it. Fractional excretion of sodium super low. Serum BUN to creatinine ratio more than 20. So BUN is going to be super high, more than double of whatever the creatinine is. Sorry, significantly more, 20 times more than whatever the creatinine is, generally speaking. And urine osmolality is going to be more than 500, which means that the urine solute concentration is going to be very low. Okay, osmolality is solute concentration, and urine osmolality is going to be more than 500. So your what am I saying? Milliosmoles per kilogram. Yeah, urine osmolality is going to be very, very high here in pre-renal azotemia. Excuse me. Over here on the side, by the way, I put what normal is. So normal urine osmolality is 500 to 800. So what this is basically saying is it's going to be pretty normal. The only thing that's going to be different is that sodium isn't going in there. Okay. Now the next one is intrinsic renal failure. So this one is where your kidney itself is not working. Right? It's intrinsic to the kidney. So now you should not be able to retain BUN. You should not be able to retain sodium, and that's exactly what you note. This is most commonly due to acute tubular necrosis, something that we're going to see on the next page. Less commonly due to acute glomerulonephritis or acute interstitial nephritis. So we saw the glomerulonephritis stuff already. Interstitial nephritis, right? AIN, acute interstitial nephritis, and ATN, acute tubular necrosis. Those are things we're going to see on the next page. Very high yield topics. In acute tubular necrosis, patchy necrosis leads to debris obstructing tubules and fluid backflow across necrotic tubules, all of which decreases your GFR. The urine is now going to have epithelial or granular casts, and urea reabsorption is going to be impaired. So here, your BUN creatinine ratio is low, and you have a high fractional excretion of sodium. You can't control it anymore. Right? So now you're seeing things that are not normal. You're in intrinsic renal failure. Urine osmolality is less than 350. Urine sodium is more than 40 because you're losing all the sodium. Right? So that means fractional excretion of sodium is more than 2%. And serum BUN creatinine ratio is not going to be super high. Okay, so super high being something like this, right? 40 to 1.3. That's a big ratio difference, more than 20 of a difference, right? 20 times, more than 20 times of a difference there. Almost 30 times higher. So that's something that really helps you differentiate between the two. The last one is post-renal azotemia. This is after the kidney. So again, your kidney is working, but something after the kidney is not working. So what comes after the kidney is basically your ureters. So this is going to be an outflow obstruction of the ureters, either because of stones, BPH, some kind of neoplasia that might have grown and compressed the ureters, or any congenital anomalies. Develops only with bilateral obstruction or in a solitary kidney. So post-renal azotemia is very rare. Okay, very rare. Now, BPH can cause bilateral issues, but again, that's also not exactly the most common thing in terms of a question. You don't get questions of post-renal azotemia that much. But the way these are named, it shouldn't be too hard to understand that post-renal means after the kidney. Right? And here, there's not much to remember. Again, your urine osmolality is going to be very low. Right? So urine solute concentration is going to be very low, but everything else varies depending on many other things. So you don't have to remember any of that. Of all of this, the most important to remember is the pre-renal azotemia. Okay, in pre-renal azotemia, you retain all your sodium, you retain all your urea, and those are the statistics you want to keep in mind. Right, so on the top, by the way, I had this from a question. So they called something hydropic degeneration. Now the word hydropic is going to be used in the book in reproductive when we talk about molar pregnancies. But here they actually used it to define something about the kidney. Hydropic degeneration refers to the pale, swollen cells seen on light microscopy in response to tissue hypoxia. Tissue hypoxia, such as that due to kidney injury, leads to a decrease in ATP production in the affected tissue, which impairs the cellular sodium-potassium ATPase pump. That is dependent on ATP. As a result, sodium and water accumulate in the cell, leading to cell swelling as seen here. This process can potentially be reversible if the hypoxia resolves, but prolonged hypoxia results in irreversible cell damage and apoptosis. So there was some question about acute kidney injury, and that's what they described. Hydropic degeneration is just a phrase that you want to keep in mind for almost any scenario. It's not just kidney injury, but anywhere where the cell is dead and the sodium potassium ATPase is no longer working, now sodium and water will accumulate in the cell, and that is hydropic degeneration. The rest of this is also continuing on about the same kind of topic. So this is consequences of renal failure. So we just talked about renal failure. Consequences of renal failure is a decline in renal filtration, which can lead to excess retained nitrogenous waste products and electrolyte disturbances. Obviously, right? Because that's what the kidney does. It manages nitrogenous waste products, helps you make urine and throw it all out, and it retains electrolytes by reabsorbing it back from the urine. So the consequences are summarized by mad hunger, metabolic acidosis, dyslipidemia, especially high triglycerides, high potassium uremia, a clinical syndrome marked by nausea, anorexia, pericarditis, asterixis, encephalopathy, and platelet dysfunction. Asterixis and encephalopathy should ring a bell for hyperammonemia. Platelet dysfunction, pericarditis are two more things that you almost never see together in a patient. So when you see both of those things, along with encephalopathy or something, you start thinking uremia, right? Uremia was on our acid-base derangements page. So uremia is often secondary to chronic kidney disease. Patients lose their bicarbonate and end up having high anion gap metabolic acidosis that is compensated by hyperventilation. Okay, so you want to make sure you remember uremia because it was one of your mud piles things. It's the U in mud piles. Sodium water retention, such as in heart failure, pulmonary edema, and hypertension. You're going to see all of those case scenarios. Growth retardation and developmental delay, if it's happening in a very young infant or something. EPO failure, right? So that's where you start seeing anemia in anyone with chronic kidney disease, right? Renal failure, because the kidney is responsible for the EPO production, and the kidney is also responsible for vitamin D. So you end up noting renal osteodystrophy. Okay, a topic that we already discussed when we did endocrine. Two forms of renal failure are your ATN, acute tubular necrosis, or chronic stuff like hypertension, diabetes, or congenital anomalies. And so we're going to be looking at all the acute forms on the next page. Before that is a quick question here from NBME 18. So it says a 39-year-old man with polycystic kidney disease has a 6-month history of intermittent blood in his urine. History of intermittent blood in urine. His temperature is 37, pulse is 100, respiratory rate is 24, blood pressure is super high. Physical exam shows no other abnormalities. His serum urea concentration is 100, which is high, and creatinine is 8. And urinalysis shows the following stuff in blood. Right, so you're looking at it, and they're asking you, okay, what would you see? So urinalysis shows blood, right? So we already know that. That's why he came in, blood in the urine. So blood in the urine, urea is 100, creatinine is 8. His kidney is completely getting wrecked, right? So now arterial glasses would show you what? And then they give you pH, PCO2, and bicarb. What would you find? Well, it's going to be A, right? And that's the answer here. The pH is going to be about 7.22. PCO2 28 and bicarb 11. How do you find that? Well, his labs show he clearly has kidney failure. So there will be defects in reabsorption. That much is obvious, right? His kidney is definitely not working. Creatinine is 8. This means he isn't absorbing bicarbonate, so bicarbonate will be well below normal. Normal is 24, 20 to 28. And only options A and D are below normal. So we can rule out B, C, and E. That was the easiest thing to do, right? Super straightforward. The body tries to make up for this by blowing off volatile acid, such as CO2. So note the high respiratory rate of 24 breaths per minute, and they gave you that. My respiratory rate is 24. That's pretty high. Usually we breathe about 15, 16, maybe 18, not really over 20. A and D both have a PCO2 below 36, so we still cannot choose, right? Because this patient has metabolic acidosis because of renal failure. So to fix that, the patient is going to start breathing really, really quickly to get rid of acid, aka CO2. However, both A and D have low acid, 28 and 19. So the pH is the final determining factor. Normal blood pH is 7.35 to 7.45. The respiratory compensatory mechanism for metabolic acidosis, which is the hyperventilating to blow off CO2, is not going to overcompensate for the primary defect. Basically, what we're saying here is that compensatory mechanism, we already talked about this when we did acid-base physiology, that compensatory mechanism is not strong enough to fix the metabolic acidosis, which means that there should still be acidosis. And that's the main difference between A and D. A had a pH of 7.22. D has a pH of 7.46. Okay, so that eliminates option D, and you just go with A. Acid-base derangement questions are extremely easy, but they don't become easy the first time you start doing them. They're pretty hard in the beginning. It takes a lot of logic and figuring out what's wrong, and then you can start figuring out answers almost flawlessly. So they're not questions you want to get wrong, and they're definitely not questions you want to get wrong. You just have to be able to reason out what is going on, and then you'll figure it out just fine. Now, although we talked about renal osteodystrophy and endocrine, it is talked about here again, right? So they do mention renal osteodystrophy. You're going to have a patient with hypocalcemia and hyperphosphatemia. Right? So this is a case scenario where it looks like the patient is going to need to make more PTH, right? Because clearly PTH is not doing its job. So PTH is supposed to throw out phosphate, it's phosphate trashing hormone, but instead you have hyperphosphatemia. You also get failure of vitamin D hydroxylation associated with chronic kidney disease. This leads to secondary hyperparathyroidism because you're going to try to make more PTH to fix this. However, the more PTH you make, it's still not going to work. So this is cool. This is very unique and very important to remember. On questions about the kidney, you can often have, PTH, calcium, phosphate, and something else written down, and then you have up and down arrows for each one. Almost always, when we say that PTH is high, we pick the answer choice that has low phosphate. But in renal osteodystrophy, it's not like that. In renal osteodystrophy, both PTH and phosphate will be high. Right? You're making a lot of PTH, but the PTH is unable to do its job because your kidney is not working. That's why it's called renal osteodystrophy. The kidney is not working. This often immediately leads to tertiary hyperparathyroidism, where you just keep making more and more PTH, but it's just not going to work. The patient will have high serum phosphate that can bind with calcium, leading to tissue deposits, ultimately causing hypocalcemia. You're also going to have very low vitamin D, which decreases intestinal calcium absorption, and all of this is going to cause subperiosteal thinning of bones. That's the osteodystrophy part. That's a very common thing that you note basically in patients with renal failure, right? And you can't really do much about it. There's an AMBOSS question right here. It says, a 44-year-old man comes to the physician because of a 2-week history of lower extremity swelling and frothy urine. He has a history of chronic hepatitis C infection. Physical exam shows 3+ pitting edema of the lower legs and ankles. Further evaluation of this patient is most likely to show which of the following. This is a really important question. We need to make sure we remember this because I've brought this up before too, and AMBOSS had this as a question too, which was awesome. UWorld also had this as a question, and the answer was increased lipoproteins. It's very important to remember that this is something that happens in patients who have proteinuria. When we were doing the first thing in renal path, let's just go back to that real quick before we look at the explanation. So when we first started renal path, we saw nephritic versus nephrotic syndromes, right? Nephritic and nephrotic syndromes, and we learned right here that in nephrotic syndrome you can have hyperlipidemia, right? So you note frothy urine with fatty casts, right? This fat stuff that's happening in nephrotic syndrome is extremely important. I put it right here that proteinuria leads to a decrease in plasma oncotic pressure, which stimulates lipoprotein synthesis in the liver. Because you lost so much protein, your oncotic pressure decreases. When your oncotic pressure decreases, your liver starts making more lipoproteins. But there will be a loss of lipoprotein lipase as well. So without the lipoprotein lipase, if you keep making more lipoproteins, you're not going to be able to get rid of it. You end up getting dyslipidemia. And this is something that gets tested in questions all the time. This was the question right here at the bottom from UWorld where they talked about it. So the answer was increased liver lipoprotein synthesis. And then right now, we're up to here. This AMBOSS question, the answer was increased lipoproteins. Right? This is something that most students tend to forget because they don't really tend to make this connection about how losing proteins in the kidney causes your liver to make more lipoproteins. So this patient with pitting edema and frothy urine, which indicates proteinuria, most likely has nephrotic syndrome, which is characterized by structural damage to the glomerular filtration barrier, resulting in a loss of protein. Hepatitis C infection is also associated with membranous nephropathy, which typically presents with nephrotic syndrome. Hypoalbuminemia due to loss of protein in the urine leads to reduced oncotic pressure, which results in a shift of water into the interstitium and subsequent edema formation. Decreased renal blood flow activates RAS to increase renal water and salt reabsorption, thereby worsening the edema. To maintain the oncotic pressure, an increase in hepatic lipoprotein synthesis occurs. Increased glomerular permeability results in lipiduria and fatty casts in the urine. Right? So very important to remember that to maintain oncotic pressure, your liver starts making more lipoproteins. That is why patients with nephrotic syndrome can have hyperlipidemia, and this is a topic that always presents because people get confused when they see, lipoproteins in the answer choices when this is a question about some kind of renal issue. If you never made that connection, you just lose that answer choice. Now, the next page goes on to talk about acute interstitial nephritis, AIN, acute tubular necrosis, ATN, diffuse cortical necrosis, and renal papillary necrosis. These 4 things are almost always, all 4 of them, answer choices for any question related to something like this. Like all 4 of them are going to be there as an answer choice. And then renal vascular disease, probably one of the most favorite topics of NBME in general. They love asking about it. And the last thing in renal path, all of your renal cyst disorders, polycystic kidney disease, tubular interstitial kidney disease, and simple versus complex renal cysts. I'll talk about all of that in the next video before we move on to renal pharmacology. So make sure you guys join the next video as well, or keep watching the playlist once I upload it again. Thank you very much for joining. I hope you guys understood the acute kidney injury stuff very well. And make sure, as always, review things and talk about it to yourself without the book in front of you to make sure you actually understood it. Yeah, so that's about it. Thank you very much. See you guys again.